Good evening, everyone, and thank you for joining our Men's Health webinar. We'll start with a few housekeeping items, and then I'll introduce tonight's speaker. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speaker. If you wish to ask a question, please type it in the chat box at the lower part of your screen, and we will have a Q&A portion at the end of the presentation to address these questions. Our presentation tonight will last for approximately 1 hour and will be presented by Dr. Stephen Pierpaoli of Associated Urological Specialists. Dr. Pierpaoli earned his Bachelor of Science degree in biology from Boston College, where he graduated cum laude. He then attended graduate school at the Medical College of Virginia at Virginia Commonwealth University. He completed his internship and residency, eventually becoming the chief resident at Loyola University Medical Center in Maywood, Illinois. Dr. Pierpaoli is chairman of the Department of Surgery at Palos Health and Palos Community Hospital. Thank you for joining us tonight, and now I'll turn it over to Dr. Pierpaoli to get us started.
Thanks, Annie. Welcome, everyone. This is Men's Health Month, so we're having a webinar talking about erectile dysfunction. We're going to go through some slides. We'll try to keep it relatively short, but we're going to have time at the end to answer questions. I get my next slide to move. It's not moving. Interesting.
Maybe you click on your right arrow or click on the screen. There you go.
So we're going to talk about erectile dysfunction and, the treatment options we have, describe what it is. And obviously it's always I think it's a sensitive topic to have, and I think doing it on this webinar, certainly any of the questions you have, write them down and put them in the chat box, and we'll be happy to discuss them with you. Erectile dysfunction is, I think most of us would know, is we don't have an erection firm enough to have adequate sexual intercourse with our partner. It's a very prevalent disease. At some point in our life, I think most of us will develop it, especially as we age, but more than 50% of patients over the age of 40 will develop it as we get older. So there's a large population of us as men who will deal with this at some point in our life. So I think it's something that we'll talk a little bit about some things that we could do to try to maintain penile health, but we're going to go through and talk about the various options we have and some of the other diseases associated with it so we can improve, men's health. So the erection process occurs, this is some cross-sectional images of the penis here. And what happens is we have to become aroused and the nerves allow relaxation of the muscle inside the penis. And there's two cylinders that allow the penis to become hard and gives us axial rigidity to have adequate intercourse with our partners. So we need adequate nerves, we need adequate blood flow, which is the arteries taking the blood into the penis, and then we need to have the veins on the outside of the corporal bodies constrict or be constricted by the hardness of the corporal bodies so we remain erect. So if there's anything to deal with the nerves, with the arterial blood flow, which is the oxygenated blood that our body puts into the penis, and then the veins, that's when we can get into issues with having erectile dysfunction. Basically the way I look at it, when I talk to my patients in the office, this is a vascular problem. And, so there's vascular issues. So we talk about people who have hypertension, people who have high cholesterol, people who have diabetes, certain medications, obviously things that we do as urologists, surgeries for prostate cancer. Very rarely, if you look at the box here, the endocrine problems, and people always say, hey, it's because my testosterone's low. It's relatively rare to have issues with the erections just with low testosterone. Certainly, the way I look at testosterone, it's the primer for the pump that makes other things work. But certainly diabetes, the vascular diseases that we're talking about, those are the things that primarily cause problems with us as we age from a sexual standpoint. Unfortunately, erections can affect our life, I think globally from a quality of life standpoint. Obviously, I think and I think anyone who's on, if you can't have sexual relations with your partners, I think it makes us, it feels depressed, which can increase, just generally not feeling well, chronic pain syndromes, things of that. So I think when we look at men's health, I mean, this is something that impacts all of our life in other aspects. I think it's hard for females to understand that. And, I see a lot of men, it's the big thing. And because we want to keep our partners happy. And if we feel like that we can't keep them happy, then, we're not happy. And I think it's hard for females to understand that, because I just think it's, different as a man than it is a woman. When we look at the, erectile dysfunction and diabetes, so obviously there's some men on the webinar tonight who have diabetes, and it affects, it's a very common, diagnosis as we age, but about 50% of men with diabetes will have issues with erectile dysfunction. And the more severe the diabetes is, the poorer quality of the erections, and it typically doesn't respond as well to the oral treatments. Now, there is one product out there that's relatively new, that's still a branded product called Stendra, which has some literature to say it may be better in men who are diabetics. But certainly that's a big risk factor for us to have problems. And diabetes, affects every organ in the body. So it can affect those nerves that we talked about. So we can get neuropathies, just like if hey, my feet are numb, we can have problems with the nerves that go to the penis. But it also affects this endothelium, which is, dealing with sort of the vascular issue. It sort of ages the blood vessels, so they don't properly dilate, they don't constrict appropriately. So, these are the things that diabetes does. And even if you control the disease, obviously keeping good control of the of diabetes and our blood sugars helps, but it still doesn't stop. This is going to affect every organ in our body. So we have to, do our job as good as we can to control our sugars, but it's going to affect our erections. So factors that increase the issues with erections in men, obviously the older we are, our erections when we're 50 aren't as good as when we were 40, aren't as good as when we were 30. How long we've been a diabetic. If you've been a diabetic for 25 or 30 years, we're going to have much more dysfunction from a vascular standpoint, because the smaller arteries are going to be more damaged than the bigger arteries. And then we know that there's correlation between, people who have diabetes with other vascular problems, either be it obesity, hypertension, etc. And those are all other things that can play a role with erection function. The other thing is, again, brings up, and I think we're going to hit on this with a few slides going forward, is, diabetes and heart disease increase the likelihood of experiencing erectile dysfunction. So we know that if you have diabetes, you have a higher risk of heart disease, heart attack, and even death. So we need to realize that if we present with erectile dysfunction, that may be a precursor by 3 to 7 years, depending on what study you believe, of causing problems with our erections and with our heart disease. So once we have erections, if I have a young man who comes in who has really no risk factors, I tend to look at it and say, hey, you know what, I'm concerned about their heart. Maybe I need to, talk to their primary care doctor, or actively say, hey, I'm going to send you to a cardiologist. Let's make sure there's not some narrowing of the arteries going to the heart. And this is, segue into, erectile dysfunction and heart disease. And I always say this is a warning sign. If someone presents to me and they're 75 and they have hypertension or high blood pressure, diabetes, high cholesterol, okay, I know that they've likely seen a primary care doctor, but they've been screened for heart disease. But I know what concerns me the most is when I get the 50-year-old male or 45-year-old gentleman who comes in and says, hey, you know what, I'm having problems maintaining my erections. Those are the patients that I'm going to say we know that it's an independent risk factor for cardiac events happening. So I'm going to send that patient for a stress test. because I want to make sure that if we're, as a urologist, we're doctors who deal with obviously men more frequently than some other specialties. And I really think we have to take that role seriously. We want to be like the gynecologists are for women. We're going to take care of all the problems. I may not be able to treat your heart disease, but I'm going to make sure I get you to someone who can diagnose it and make sure we're not missing something. The one other thing I want to touch base at, it goes back, but I won't go back in the slides, but the other big risk factor from a vascular standpoint, let's just go through them again: diabetes, high blood pressure, smoking, high cholesterol. Those are the big risk factors that we have. If only thing that we can really fix ourselves, anybody out there who's smoking right now, talk to your doctors, come in and talk to us. There's medicines to stop smoking. That is the biggest risk factor for erectile dysfunction that we can control. We can't fix if we're going to have heart disease, because sometimes that's genetic. We can't fix our cholesterol, again, genetic. We can stop, put our cigarettes down. You know, we save $8 a pack or whatever it is. And that is something that I really want to hit home. We have to stop smoking as men. It's not good for our men's health. So here you can look at, we look at erectile dysfunction, the size of the penile arteries, 1 to 2 millimeters. You go to the femoral artery, which is the large artery that brings blood flow down to the lower extremity. It's 6 to 8 millimeters in size. So to typically have issues with, obstruction in the leg, so in that femoral artery, you really have to get down to, 50 to 70% of that vessel has to be blocked off. Well, if you have a 2 millimeter vessel, there's not as much to block off. And that's why a lot of patients will develop symptoms way before from an erectile dysfunction compared to the size of the arteries that go to the heart or go to the, go to the brain or go to the leg when we walk. Because of the size of the arteries, they're small. So if they're smaller and we bring them down, it doesn't take that much, and we just don't have enough blood flow to get there, and to get enough blood flow to get a quality erection. The things that we can do, what can we do? You can see there, quit smoking, big thing. Obviously, weight loss and keeping a adequate exercise regimen, very important. I think if you look at, studies across the board, I think they've recently changed even the exercise requirements. It should be 5 days of a week of, more than 30 minutes of, vigorous exercise. Let's get out and walk with our partners. It helps us reduce stress, which plays a role. Our diet, let's stay away from, obviously red meat's okay at times, but cut that back. Let's get into more, chicken and fish, and, not having, fried foods and things like that. Those are things that we can do to try to improve our heart health, which will play a role with us maintaining our erections. I think we can reverse it? Likely not, but certainly I think we can decrease the likelihood of the disease progressing and our erections getting worse. So all of a sudden, some of the treatment options we have available don't work as well. We'll touch base a little bit on, low testosterone. And again, it's a rare thing. I mean, a lot of men will have low testosterone, and it happens as we get older. Starting at the age of 50, our testosterone levels begin to go down. We typically peak in the morning, and that's when we usually will test the testosterone level. And what does testosterone do for us? Well, it gives us our sex drive. So anybody who has had prostate cancer, and some men have been treated with medications to reduce testosterone, first thing that happens is your sex drive goes away. Now, interestingly, some men, even with incredibly low testosterone, still can get erections, but you just don't have the desire. And then we talk about the, body composition. Typically, as we age, most of us will notice that our abdominal fat pad will increase, and sometimes we'll get a suprapubic fat pad, etc., that sort of allows the penis to look smaller. Functionally, it's probably the same size, but it looks smaller because our fat tends to go down to that suprapubic area as we get older. So I tend to, if you come in and you have a normal desire, and you have a bunch of vascular risk factors, I still think it's reasonable to check the number, but I will tell you, I think it's the rarity that we correct someone's testosterone level that there's not some underlying vascular problem that's also playing a role with their erections. Now, if you come in your age 30 and you're having problems with your erections, I certainly think, we check the testosterone, it's low, we make it better, you're going to get better. But it's very rarely is it the primary cause of problems with erectile dysfunction. The signs and symptoms of low testosterone, we talk about, hey, I don't sleep as well, so fatigue, loss of energy. Hey, doc, my workouts at the gym aren't as good, so our muscle strength is decreased. We get more body fat. We lose hair. Don't have to shave as much. And then just not, from a mental and emotional standpoint, not feeling as well, less motivation to do things, less sex drive, and then, potentials with erectile dysfunction. Again, think of testosterone as the primer that makes things work better. Again, you can, we can take an 18-year-old kid, and if they've lost their testicles in an accident and their testosterone's low, they'll still get an erection. You do that to somebody who's 50 or 60, that's likely not going to happen, just because of some of the other vascular things that tend to happen as we age. From a testosterone standpoint, there's multiple ways to, even more than this. There's oral medicines, there's nasal things, there's patches that we can put on, there's injections, there's implantable pellets that we can go in there. We do need to be careful. Testosterone, we don't want to go to the gym and get it, and use these super physiologic levels or get super physiologic levels. We have to worry about men's blood getting thicker. We have to worry about the potential for, changes in, the vasculature. There's some studies that say, old testosterone shot at the gym, not really the best way to do it. If you have low testosterone, do it under the care of your primary care physician or your urologist or your endocrinologist, and I think that's the way to go. And we look about, unfortunately, prostate cancer is, it's the most commonly diagnosed cancer in men, the second most common cause of death in men, and the treatment that we do for it, be it surgical therapy, be it radiation therapy, unfortunately can affect the nerves and affect the blood flow to the penis. So it is a cause of erectile dysfunction. You can see here a picture on the right. You see where the prostate is, and depending on age, a lot of men will undergo prostatectomy, where the prostate's removed to treat the cancer and cure it. Well, unfortunately, God put our nerves that go out to the penis right at, at 5 and 7 o'clock on the next to the prostate. So if those get damaged during surgery, either be it by electrical current that we use to control blood vessels or just actually being cut, we're going to have issues with getting an erection. And there's two nerves. There's one that goes to each corporal body, which are those cylinders we talked about in the penis. I usually will tell patients, if you have bilateral nerve sparing procedures, about 70% of men will maintain adequate sexual function, but it may take 18 months to get it back to normal. So after 18 months, if it's not back, it's likely not going to come back. But that's, unfortunately, do we maintain erections, or do we, not cure our cancer? So obviously cancer trumps, but it is something I always tell my patients, there's things that we can do to get erections working afterwards, but we can't cure prostate cancer if it's gone too far, or if we try to aggressively save those nerves but leave cancer behind. Sexual, dysfunction, again, I think it's a lot of men will have it. I typically use a little bit of a different number with radiation, and I usually say initially about, everyone will maintain relatively good, but we'll notice, because it, as it causes sort of the blood vessels to be damaged, and the corporal bodies where some of the arteries come in can be damaged from the radiation. We'll see a slow decrease in erections over time. And that's different than what we see with prostatectomy. When you do surgery afterwards, right away, you're going to have issues, with erectile dysfunction. And again, we have to look at what men, if you come in and you've been smoking and you've had diabetes and you have high blood pressure, you're not going to do well after surgery for prostate cancer from an erection standpoint. Then we can talk about Peyronie's disease. I think that's been on TV a lot, and basically that's an area, typically where you'll have some fibrosis that happens in those corporal bodies. And you can see a picture here. You get these fibrous plaques, and the reason why they develop is typically it happens more in men after the age of 50s, where our erections may not be as firm as they were when we were 20. And when we're having sexual relations, we'll get sort of torquing of that area, and the corporal body has a longitudinal and circular layer of this collagen tissue, and it sort of gets traumatized, and then the body sends cells and fibroblasts which put down this fibrous plaque, and when that happens, then the penis can't get as long as it did, and we can get curvature. So obviously, and really when it's bad, it could cause erectile dysfunction, but I think they sort of go hand in hand. But I usually will say if there's a mild curvature, at that point, and you can still have satisfactory sexual relations, you let it be. But it certainly can affect the way the corporal body functions, and it can affect our erections. What people will see, I mean, most of the time in my experience, on very rare occasions, unless there's significant penile trauma, it doesn't happen overnight. But I'll have people come in and say, Doc, I was having sex and I was in a particular position and my penis hit the wrong spot, and I had some discomfort, and then they go to have sex the next time and they have curvature of the penis. Typically what we'll feel these hard bands underneath the skin. And you can either have curvature, or you can almost get like this hourglass deformity where it'll sort of come in, and that obviously affects the way we can get an erection. But the biggest thing that people complain about is penile shortening. In the first year, people typically will have penile pain, typically with erection, but sometimes without erection. And that tells us that it's in the acute phase. And in that situation, we're going to typically try to sort of see how it's going to go. Is it going to get better on its own? But we really want to try to stop that inflammatory reaction from happening. So if anybody knows anyone who has trigger fingers and things like that, it's actually associated with these things, but it's basically excess collagen. So your body keeps saying heal, 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 but it keeps putting down fibroblasts, which puts down collagen, which is what causes scar, and then we end up with a penile curvature. There are many treatments that we have for it. Xioflex is a medicine that's it's a collagenase. So collagen is the scar tissue. Collagenase, anytime we put A's on a word, it's an enzyme that will break that down. Now, sometimes at the beginning of the disease, there's medicines that we can give to change how that healing process is occurring there, to try to decrease the inflammatory process that's happening there. There's obviously surgery that can be done. So penile plication is where, hey, we have a scarred right corporal body, and when we get an erection, that corporal body can't get as large. Hey, we're going to go to the left side, we're going to shorten it. Obviously, most of us as men, we want bigger and longer rather than shorter, but that's what a plication procedure is. Sometimes we have to cut out the whole scar, and we can put a patch on it so that doesn't happen. But those operations can affect the way our erections work. In people who have significant erectile dysfunction, who don't have satisfactory erections, penile implants, along with either with excision of that plaque, is really a very viable treatment option. When we look at the things that we can do to improve our erections, you can certainly talk to your primary doctor about it. Then you have a urologist, such as myself and the partners in my group. And then a prosthetic urologist is someone who's done additional training in men's health and erectile dysfunction. And essentially, they've done a fellowship. Urologists typically will do 6 years of training, and where they really focused on dealing with erectile dysfunction. But certainly, I think we can. Let's talk to our family doctors about it. Now, I think, unfortunately, I think they tend to be, busy because there's a myriad of things they're treating at. I don't think they have the time. So I really think if there's issues, the urologist and the prostatic urologist, they're really who are going to do most of the treating of the disorder. So when we look at I always talk to my patients about going upstairs, and when we look at the options that we have, I mean, most of us, if I could take a pill to fix something, I would prefer to take a pill. And so those are the oral medications. Then we have penile injections, and that's where medicine is injected directly into the corporal body. And then there's vacuum devices, there's urethral suppositories, which we'll talk a little bit about. And then there's penile implants. And I mean, that is a surgical procedure, but I could tell you in patients who have had them done, and they're going to be happy with it when they do it, and so is their partners. So when we look at oral medications, we call them PDE5 inhibitors, and they work on an enzyme to make that enzyme stay around longer so we can get more blood flow into the penis. Now, you can't just take the pill and get an erection. Now, depending on which ones you take, thankfully they've gone generic, at least a lot of them. So the prices come down. That was the real rate limiting step 5 or 6 years ago. They were $50 or $60 a pill. So when we look at things like Viagra and Cialis, they have some different ways in which they work and how long they last. But you can't take them more than once a day. And, when they talk about the efficacy being affected by food, that's really with sildenafil. Okay. Sildenafil works quicker than Cialis, and you have to take it on an empty stomach. I really think it depends on how bad our erectile dysfunction, if they work. If you haven't had an erection for 5 years, the likelihood that the oral medicines are going to work is low. Prostate surgery, it depends on if the nerves are intact. So if you've had a surgery on your prostate and the nerves have been damaged, they're not gonna work. Men with diabetes, again, as we talked, sometimes the medicines don't work as well as that. Now, Stendra, which is a branded product, has some literature to say that it does work better in this population. Side effects, headache, flushing, stuffy nose, and upset stomach. Now, the only thing, that it's absolutely contraindicated in is with nitrates. So nitrates are medicines that typically are given by our cardiologists or our primary care doctors, which allow the blood vessels to the heart to dilate. So if we're having chest pain or what they call angina, it'll improve that. That by dilating those blood vessels. I mean, interestingly, the medicines were actually developed, so Viagra was developed in England, and it was developed to be used to dilate blood vessels of the heart. And then the men were coming back and say, hey, my erections are better. And that's when, we sort of found out about these medications that they were trying to be used to take over for nitrates. So but if you take them and you're on a nitrate, or you get called by the paramedics, get called because you have chest pain, and they give you a pill underneath your sublingual nitrate medicine, that's when people get into problems and have significant low blood pressure, and where people could die from it. So we have to be real careful with that. As far as people, there's multiple studies with using these medicines on people who've had on 2 or 3 different blood pressure medicines. There's really not many things that worry me. If people have something called retinosis pigmentosa, which is an eye disorder, can't take it, and the nitrates is the big issue. Then when we look at vacuum devices, I think most of us excuse me, have seen these certainly on the internet and whatnot. And it's basically a vacuum. It's a plastic tube that goes over the penis, either with a hand pump or a battery powered pump. We allow blood to get sucked into the penis, but it just doesn't go into those corporal bodies. It goes into the skin and whatnot. And then we put a tension ring at the base of the penis. It works, probably 70 to 80% of men. The problem with it is, we'll talk about the next thing, is when you don't, with the ring on, you can't ejaculate. So that's uncomfortable. You can get bruising of the penis, and the penis tends to be numb and cold. And some of our partners are able to feel that. The most reason why people stop it is the problem is you have the ring at the base of the penis, but it'll be sort of floppy, proximal, or closer to the body with that ring. So sometimes the mechanics of it is difficulty. And certainly I think if we're going to a bar and dating, it's not really the ideal thing that I think your partner wants to see you putting a vacuum on your penis. We'll talk a little bit about urethral suppositories. It's a branded product called Muse. I think it's now gone generic. And basically, it's alprostadil is a medicine that is a prostaglandin. And if we put it into the penis, the idea is it's going to get into those corporal bodies and it's going to allow dilation of those blood vessels, and we're going to get an erection. I think it works about 50% of the time. The concern of it, you have pain in the penis because alprostadil is prostaglandins, and prostaglandins are what give females their menstrual cramps and stuff. So you can get pain in the penis, and not just by putting it in. It can lower blood pressure. And I think they're quite expensive. So I have to admit, I don't use them much in my practice. I do use intracavernosal penile injections. If you guys have seen any of the signs driving down the highway for Boston Medical or these other quote unquote Mayo Health clinics, that's what they do. They teach you how to do an injection of medication into the corporal body. Typically, you do it about 10 minutes before you have intercourse. And, about 60 to 80% of patients will be happy with it and it will work. The problem with it is nobody stays with it. So by the end of the first year, most people, only about 20% are still using. Most of us as guys, we don't think of our penis as a place to put, in needles. But it is a reasonable treatment option. And I have men who've been doing it for 5 or 6 years and quite happy with it. We do worry a little bit about that penile fibrosis or scarring happening, which is sort of like a acquired peyronies disease. So typically we want you to, hey, one time put it on the right side, another time put it on the left side. Penile implant. This is a mechanical device. And remember, we have 2 paired cylinders in the penis. And basically, we put an inflatable cylinder in, and then we have a pump that's down in our scrotum, and we have a reservoir where the fluid is maintained. So if we want to get an erection, we squeeze the pump. That's you can't see it. And interestingly, I've had some patients say, "Oh, I've been with a lot of women. No one even feels that I have a pump in my scrotum." And so you inflate the device, and then you get a hard erection. You're able to have intercourse. And even if you have an orgasm, it doesn't go down. It doesn't go down until we hit the deflate button and it goes down. Now, this is where when we look at, satisfaction that people have. And, when you look at the other ones, we're talking between 60 and 80%, depending on which one we're using. Really, I tend to look at patient and partner satisfaction. And I think it's, in the mid 90s where people are very happy with it. And they tend to, it works. We know that you're going to be able to use it when you want to use it. You never have to think about taking a pill. You never have to worry about putting a needle in. You don't have to worry about vacuum devices, etc. And they last for quite a while. I usually tell patients that 95% will work for 7 years, and then about 5% will fail thereafter. Because it's like a tire in the car. What it's made up of can sort of break. I've had people, use them for 15 years and they're still working. So everyone's different with that. The biggest side effects is obviously you have to have an operation to do it, but it's about an hour and, between an hour and an hour and 20-minute procedure. But it is a mechanical device, and that's always the thing. So if it breaks down, unlike our car, where we can just open the trunk, well, the idea of opening the trunk on our penis doesn't work. So we have to go back in there and repair it. Infection is a big thing. Now, some of the products from the company and Boston Scientific, they've basically impregnated these devices with antibiotics that really have decreased the risk of infection by 50%. But it's like any other foreign body that we put in. If we get a knee replaced, if we get a hip replaced, that's a real problem because it makes it hard to get something else back in there. So it's as low as we can, but it's never zero. I think this is a video that just is an animation that will show you how to do it. I have another video, but I'm not going to show it that shows the real thing. But this is really how the implant works. And it'll show you where the various components are. So you can see he's pressing his pump in the scrotum, and then that reservoir that's tucked next to the bladder where you can't feel it or see it, then that fluid transfers into the cylinders and we have an erection. And then he's finished having sexual relations and he hits the deflate button, and the penis returns to its normal state. And there's multiple different types of prosthesis. I think most people at this point are using what we call these 3-piece penile prosthesis because they can be concealed so much more easily than the rigid or malleable prosthesis that on very rare occasions we'll still put those in. I'm going to skip this slide. So benefits of a penile implant. It's a permanent solution. It's once it's working, it's going to continue to work. We did say it can break down. It's spontaneous. You can have sex when you want. You don't have to worry about putting in an injection in. You don't have to worry about taking a pill and making sure you time it right. You can have it, if you've had food or not food. The erection lasts as long as you desire. No one can tell you have it. If you go to the airport, the screener can't tell that you have it, etc. The big thing with it is the high patient and partner satisfaction. It's one thing for us to be happy, but I think most people who have these are people who want to make their partner happy. And basically the satisfaction rates from a partner standpoint is about the same, in that mid-90. They've been around for many years, and there have been, probably over 500,000 people treated. It doesn't affect the way we experience orgasm or ejaculation. Obviously, if we've had a procedure on our prostate and we don't have a prostate, we will have orgasm, but we won't have ejaculation. This doesn't affect that either way. Just a quick thing, Medicare and most private insurance companies cover it. Certainly we do due diligence before, and people would know, if it's covered. We have help from the company, and we can certainly go through all that for you. With any surgery, like we talked about, there are risks, and we have to know about those. And the things that we talked about, the mechanical failure can happen with time, and sometimes it needs to be removed or replaced. And if that happens, it does make it a challenge to get another one in, because we typically will get scarring in those corporal bodies, which will make the penis shorter, etc. And at the beginning, you're going to have some discomfort. And most of the time, people can go home the same day or the next morning, and, within a week be back to relatively normal functioning. It takes about 6 weeks before we'll be able to activate the device. You need to let it heal before we do that. So in summary, it's a very common problem that we have. There are many treatment options that we have, and a penile implant is a permanent solution, which the other ones aren't. So I think you should, it's something that we should talk to our partners about, and also, talk to your urologist about it, and go from there.